Good evening. Welcome to the Nat Health Leadership Outreach Series. This program is meant for the frontline workers, our COVID warriors, those who are really responding to patients, the frontline and saving lives. This is a series which has been designed for providing answers to some of the questions that has been posed by the frontline workers. And it's meant as advice, counseling, and support for those frontline heroes. We are very, very privileged today to have with us Dr. Ashutosh Raghuvanshi, who is the MD, CEO, and Executive Director of Fortis Healthcare Limited. Dr. Raghuvanshi is a seasoned healthcare professional with an illustrious career spanning over 27 years. He's successful and well-recognized, renowned pediatric cardiac surgeon with a proven track record as a successful clinician and an able administrator. He's an acknowledged business and management leader, and is known for his strong track record of building successful healthcare organizations while leading great teams, creating structures and processes whilst delivering exceptional results. Dr. Raghuvanshi is presently the MD, CEO, and Executive Director at Fortis Healthcare Limited. Prior to joining Fortis, Dr. Raghuvanshi was associated with the Narayana Health for over 20 years. His last stint at Narayana Health, he served as Group Chief Executive Officer, Managing Director, and Executive Vice Chairman. A very warm welcome to you, Dr. Raghuvanshi, to this program.
Thank you, Siddhartha. Thank you for having me.
Dr. Raghuvanshi, as a leader of one of the largest and the most prominent healthcare chains in India, how involved is your leadership team and your HR teams today in resolving the stress and the burnout issues over the last few months? Are there some examples you may just bring out for the benefit of the audience, please? Thank you.
Yes. I think an engagement at all levels at all the times is very important. I think during the pandemic, it becomes even more important to ensure that people who are at the forefront, they are well protected and they have a feeling of security. So right in the beginning of this pandemic wave, before the first wave started and we started seeing the early lockdowns, we had taken several measures as an organization to ensure that there is enough communication and then there are enough supportive measures which are put in place. So for example, there are a lot of staffs in hospitals which are covered under ESI and they don't have access to the normal insurance. So sometimes they are not able to access services of their own hospitals. So first thing we did is that immediately ensured that they all were also covered by an insurance so that in case they required hospitalization for any reason, they could be provided care within our institutions. So that was one of the most important steps which made people feel taken care of and protected as well. The second thing which we did is that we increased the insurance coverage for everybody so that their families also feel secure. But early on, the first phase was very different from the second phase. At that time, as you know, that people were not immunized. And there were a lot of arrangements had to be done in order to protect families of our colleagues. We had to create some pickup services. We had to create because the transportation was not there, then hotel accommodations, etc. So all those measures were instituted. But I think what was most important is that the entire leadership team made sure that all this is communicated regularly at various levels to people at regular interval. At the same time, protocols were set in, and all that was also disseminated rather quickly, how to protect themselves. A lot of video modules were prepared as to how to don and doff in the PPEs, etc. And all those helped people to learn all this thing and feel secure. This is how I think the early engagement started. And I think I must say that, you know, the biggest inspiration for us is the frontline people who are, you know, always there to take care of the patients. And I think the inspiration we get from them is what drives the leadership, actually.
Very well put, sir. Every day, I'm sure over the last weeks and months and years, there has been examples of, people's victory in a way. There have been, I'm sure, occasional setbacks, but there are more successes than failures in this journey. Could you maybe tell us or share with us some of the experiences that you have really seen in the front line, and what lessons do that hold in the way we are fortifying ourselves in the journey ahead?
Yes. So I think few examples, if I have to say that what was happening on the front lines, and unfortunately, I was not so much directly going into those areas. So majority of my information is sort of through my colleagues who were right there. But I think there were inspirations coming from everywhere. Especially from the front staff, and I would say that it came from every cadre, be it the security people who sort of, you know, who we put in a training program for them, and how they, after the first module, how they trained themselves, and how some of them took the charge in training their other colleagues as to how to take the temperature, how to discern whether, you know, a person could be a potential patient, how to segregate people, how to isolate quickly, and all those things they developed it themselves, you know, after giving a very cursory training in the beginning. So those are the examples of how people have evolved during this phase. The leadership has come at every level. And most of the time, because of the restrictions in travel and all other limitations of going everywhere, what we realized is that leadership started emerging at every level, whether it was the head of a hospital, whether it was head of nursing, and even various departmental heads, etc. So I think one of the best thing which emerged, in my view, out of this whole very unfortunate situation was that we could see how people can step up and become leaders in their own right at various levels. And I think if people had not sort of taken that kind of charge at every station wherever they were, things could not have been managed at all, because of the breakdown of the of the transportation channels, the supply chains, etc. A lot of improvisation had to be done, and that required a lot of the thinking on the feet from the people who were doing various jobs in various positions. There are some of the people who don't really come into our vision is, like, for example, supply chain people. During the first phase and even during the second phase, there were certain situations where their role was extremely vital and critical, and they had to really use all their ingenuity and resources to ensure that the supplies don't get diminished. During the second wave, unfortunately, we saw a very, very severe situation where people were struggling for the basic resources, and at the same time, the hospitals were struggling for very basic resource of oxygen. And we had several situations where we were just at the brink of a disaster. And at one stage, we were all sort of, just ready to give up. But some of our colleagues from supply chain and logistics here and there, and even external supporters of the organization helped to overcome those crises sometime at the very, very last moment, fortunately for us and for all the people we serve. Some of the deficiencies still remain. So I must say that some of the stakeholders, some of the partners in health sometimes go unnoticed, and that is the suppliers, vendors, and also the support staff in the hospital, especially the supply chain and administrative people.
Very well put, Dr. Raghuvanshi. There are so many unsung heroes, unnoticed heroes, but all of them, including you, who may not touch the patients directly, but each of their roles are so important in the way ultimately services are delivered. The next question, Dr. Raghuvanshi, is really in terms of you being a national player, one of the few players in India, in India's fragmented healthcare system, where you have so many states where you have presence. Do you see your frontline staff in any particular region or state being affected in a different way than another region? And what lessons does that have in the way you cope with emerging scenarios moving ahead? There may be lessons from a region which may be relevant not immediately in another region, but going ahead.
Yes. So I would not say that there were any regional differences in the way people were impacted. I think the timing of peaking of disease was different. Intensity of the peak wave was different in different parts of the country. Having said that, did not really make much difference as to how people had to respond. Now, few things which are sort of, logistic issues are there. Like, for example, in a city like Bombay, there is a different kind of, say, local transportation issues, etc., compared to Delhi. Now, in Delhi NCR, typically, the NCR falls into 3 different states. So there were some very peculiar issues where people were living in one state and working in another state, and they had to pass through the third state. So say if somebody living in Noida and who's working in Gurgaon and vice versa, that was extremely complicated because of the restrictions during the first wave. So these are some of the things which differed. The other thing which I would say is that the intensity of the second wave in Delhi was very concentrated. It happened over a short period of time. The peak was achieved in a very short period of time, and people were unprepared, whether it was patients, authorities, and I think hospitals had also started becoming a little sort of relaxed in thinking, in their thinking. So because of that, I think the ferocity with which the wave came and the intensity of it was so severe that people were really at extremely stressed out in Delhi NCR. Compared to that, though, Bombay also had a very severe wave, but that gradually sort of became intense. So because of that, it was spread out and it was managed relatively better, I would say. So that way there was a difference. The other cities largely did not face the similar intensity as Delhi and Bombay. I wouldn't know the exact reasons, but my hypothesis is that this is because of the population densities in these two areas. by that logic, Calcutta also probably should have had similar situation, but it was relatively better, and so was Bangalore and Chennai.
Dr. Raghuvanshi, one of the questions, and I'm just looking at some of them, and in fact, common theme is the way the pandemic has shown us it's a sinusoidal or a wave, and it has its peaks and troughs. But there is one constant, which is the non-coronavirus patients. It is just accumulating, right? There's no curve. And every year, India has the medical infrastructure in India is inadequate to deal with all the caseloads that are there in urban, peri-urban, rural parts of India. The last 1.5 years, there's been a significant backlog that is being created on non-coronavirus patients. Do you feel that going ahead, this backlog, along with if there is another pandemic wave that comes together, this may overwhelm the healthcare system? And if so, what should we do now to ring fence these so that we are able to load share and manage both of these over a period of time?
Yeah. No, very, very good question and very pertinent. My biggest fear is that a lot of people who have chronic diseases or are diagnosed with illnesses other than COVID during this last 1 year, that would be a huge number. And most of those patients have not undergone the kind of treatment they would have gone if it was a normal year. So all that backlog was already there. That was not coming back for treatment. And the second wave has hit. And we do not know how the disease will progress further. The problem with all these patients is that those who say require treatment in early stages, certain other kind of treatments and better outcomes are possible. Whereas if the patient is not treated at the right time, then sometimes they may become inoperable or their outcome may not be that good as well. So it is not only the sheer numbers which is going to be a strain for the system, but it is going to be also that these patients would be having higher morbidities, and they would be less likely to recover or benefit from the procedures or therapies they undergo. So it is a matter of grave concern, I think, and the policymakers have probably overlooked this to a large extent, and not any specific steps have been taken in that direction, at least of what I know. The only saving grace, what I see, is in the second wave, because all the physicians and the frontline staff is immunized, and it is very clear now that post-immunization, definitely, even if someone gets exposed and gets the disease, usually it is likely to be very mild. So because of that, there is a better understanding of all the isolation measures, the security of the vaccination, etc. So the healthcare delivery is also a little more confident than what it was during the first wave. So I believe that this time the recovery is going to be a little faster. We only saw about a month when the non-COVID work went down. We already see that some of the non-COVID work has started coming back already, in spite of the fact that we haven't really come to the baseline yet of the COVID peak. Because of that, I think for now, the situation would be slightly normalized. But having said that, there would be a large number of patients who may not have been treated during the first as well as the second phase, and they would have sort of bad outcomes if they're not treated in time. And that is going to increase a additional disease burden over the whole system. So the only thing which can be done is to encourage that early resumption of non-elective work in as many hospitals as possible, especially the smaller hospitals and areas where the numbers of COVID patients has gone down. The faster that recovery happens, the lesser will be the disease burden in the long term.
Thank you, Dr. Raghuvanshi. A connected question to that would be, you know, over the immediate future, there is a need then to really build up the capacity or the throughput out of the healthcare system, both at its base capacity level as well as the surge capacity, which is required to deal with the pandemic. Any thoughts, Dr. Raghuvanshi, about in the urban areas, how that could be accomplished, particularly as you move away from urban areas, as the virus is mutating and is going to rural parts of India? Health infrastructure is anyway at a pretty rudimentary level compared to the cities. What would be some of your thoughts in terms of how the policymakers, private sector, the other stakeholders could quickly build healthcare capacity, not only to deal with the pandemic, but also to create a stronger health system foundation? It's clear now that health is wealth, and there is a large dependency of the overall economic output to how health is doing. So what would be some of your thoughts in that area, sir?
No, I think you said it very well that this pandemic has only brought into focus a fact which was already known, that the healthcare infrastructure in the country is very inadequate. And I think the most unfortunate part of that is that healthcare infrastructure, the physical infrastructure, is not which really delivers care. And the care is delivered by people. And I think the lack on the human resources is not something which can be fulfilled in a rush. To train a nurse, it takes at least 3 to 4 years. And after that also they require on-job training. So to get a good critical care nurse, it takes at least 4-5 years before they can be good professionals. So with those limitations, I feel that there are short-term measures which may be taken, but those short-term measures are not going to be extremely helpful. Now, during this pandemic wave, there were a lot of ideas floating, and as the WhatsApp and all other forums were buzzing with ideas, there were a lot of ideas coming, like let's call the retired doctors to give care to COVID patients, for example. Now, I haven't heard of a more absurd idea than that, because those people were supposed to be protected at that time. Those who are retired are obviously high risk age group. So they cannot really do that, but they can do other things for sure. So I think one of the major things which need to be thought of by the policymakers is to how to include more people who are excluded out of the system. Now, in our country, there are the way the education system has been structured, it causes a lot of inefficiencies in terms of how much time people have to waste during their training programs. For example, after an MBBS exam, students have to prepare for years to sometimes those who are lucky and fortunate get in early, but sometimes they have to wait for a couple of years to get into the postgraduate exam. And during that time, they have to keep on sitting and preparing for an entrance exam. Now, medical sciences is not taught in the classroom, because the classroom training students can do on their own. Today, the knowledge is liberalized. It is democratized. It is available in so many forums, in so many ways. You don't even have to be a doctor to understand physiology anymore, because if you want to be a student of physiology, you can be so. So I think the reform is required, because the bedside training, the patient, the students who are training to be specialists or even general practitioners, they need to be with patients. And I think we are taking them away, and we are giving them a system where they have to struggle for a long, long time. Now, if the country has so much shortage of specialists, why is the entrance exam giving only 30-40% people, or even lesser sometimes, the opportunity to become a specialist? Lot of times I have a disagreement with people who say that, oh, the quality would suffer. And that is not really, an important point, because if the quantity is less, then the quality doesn't matter. Long back when I was a medical student, in a surgical book, Love and Bailey, there is one of those dictums that a bad doctor on the bedside is better than a good doctor 100 miles away. So I think when we have so much shortage of specialists in this country, I think the first step is to train those people, because it takes so much time. It takes 3 years, 4 years, 6 years to train certain specialists. So it's better to train those people, and then the system will take care of the quality automatically over a period of time. If a doctor's outcomes are not good, nobody is going to go to them. So I think the reform in medical education is even more important than whatever short-term measures are taken to overcome the current shortages. Now, immediate measures could be many. Some of those examples is that, getting all the retired doctors back, etc., in the government system. But the public healthcare system has to improve. In a country like India, just the private healthcare sector cannot take care of the needs of this nation, because majority of patients cannot afford a private healthcare system. Now, why is that? Not because private healthcare system is expensive. In fact, it is one of the lowest priced system in the world. Compared to any other countries, even in the Asian context, if you see the cost of a procedure, say a bypass surgery in India versus in Thailand, it is like hardly anything. But the problem is that the ability, financial ability of majority of population is such that they cannot afford even that. So that, in order to compensate, the public healthcare system has to rise up and take on the responsibility for those people. And that is, there is no substitute for public healthcare system in a country such as ours. And I think for next 10, 20 years, there is no substitute for that. And that is extremely important. Now, many times I have seen that the discussions either get too focused on the payer, or they get too focused on the provider. No one is trying to look at the entire piece, and no one is trying to look at what are the deficiencies in order to provide that comprehensive service to the population base we have. So I think it is a very, very important that that is done. So one of the things which I believe is a problem is that the many elements of the healthcare delivery are very, very fragmented. It's a concurrent subject. So the states have different views, center has different views, pharmaceutical is under a chemical ministry, something is under health ministry, something is an autonomous body. Now, all that needs to be coming under one common umbrella. And I think the health ministry should be that umbrella, or any such body what the policymakers can come up with. So I think that is very important, so that there is a overall comprehensive view of what needs to be done for the country, rather than what limited measures we can do to a particular segment. I think that is very important. Now, and all these things are, though long term, but they need to be initiated at some stage. Unless they are initiated and the system is not reformed, it is never going to be reformed. And it cannot be done in small pieces. It has to be done from the grassroots. So in my view, unless that happens, any short-term measure you do of creating some infrastructure, it is not going to yield the satisfactory results for now. So for now, the only solution is that provide as much care as possible in the given infrastructure, and that is what which I think the focus should remain now.
Thank you, sir, for that very well-rounded answer. Coming to the topic of vaccines, India has had a lot of experience with door-to-door vaccinations. The polio programs, they have been done over a relatively longer period than what we are currently faced with. The current challenge for India is really vaccinating almost 90% or maybe slightly less of that population, but really over the next 1 year period. What are some of your thoughts in the way we may be able to accelerate the momentum of vaccination, and how do you see the virus behaving as a larger section of the population, for example, get vaccinated? Going into next year, do you see something substantively different than what we are seeing this year?
Yeah. No, there is a fundamental difference in vaccinating for an endemic disease versus a pandemic. So polio, though, was an extremely large effort and almost like unbelievable and in its scale. However, there were no short time spans in which it had to be done. Two, the vaccine was well established over a period of time. It could be given in a form where it doesn't require too much of supply chain constraints. So with all those advantages, it could be done. And it doesn't require skills. It was not an injectable form. It did not require any observation. It doesn't require any special infrastructure, observation, trained staff, etc. So it was very easy to train somebody to give drops, and it could be done at a mass scale. So, and that is one major difference I think we have to keep in mind. Now here, the supply chain where the cold chain has to be maintained, etc., is one of the constraints. Then it is an injectable observation has to be done. That is the second constraint. So with these two constraints, I think it is difficult to plan a very good program which can immunize almost the desirable number or percentage of our population rather quickly. So it is difficult. Having said that, I think it has not, it needs to be planned a little better. The deficiency in the supply side of vaccine is adding to the problem further. Then there are too many different, kind of discourses which are happening, which are changing the goalposts on a regular basis. Like what is the duration between the vaccines, whether you could just take one vaccine, that is the new debate which has come. So trying to adjust the program to the availability of vaccine is not the right science. We should go by the scientific the version only, and then plan the program according to whatever vaccine requirement is, rather than fitting the requirement into whatever the availability of vaccine is. So I think there is a fundamental disconnect over there, and I think that bias needs to go. And then there are a lot of other problems which have come. There are segments that private hospitals will do it like this, public hospitals will do it like this, the supply will go from center to state. All those things are also not resolved. In my view, it would have been very easy and simple if there was just a unified system where people could walk into, just by registering, they should be able to walk into a center, and the moment their vaccine is given, that information goes into the system. that much of administrative activity could have been done easily. But this current procedure where, people are supposed to go onto the app and apply, half the population in this country cannot do that. They're not skilled enough to do that. And I think these are artificial barriers which have been put to the access of vaccination. So in my view, it would be better if this is simplified as much as possible. Of course, there is a constraint of supply, but we should not see, eventually when you're trying to achieve the immunity, you are trying to get a certain critical mass vaccinated. Now, whether that mass is person A, B, or C does not matter. It has to be, we cannot decide that only A and B has to be vaccinated. That will cause the herd immunity. No, it could be any two people. I'm just making it up, but the exact percentage to achieve herd immunity is approximately 70%. But it could be any 70% people, not necessarily 70% people above a certain age or below a certain age other than children. So I think these ambiguities, if they are removed and the procedure is made very simple and just let people get immunized at their own will, I think we will be able to achieve very much our objective. But having said that, I must say that in last few weeks, we are seeing that the system is gradually emerging. And now I'm quite hopeful that by December, we should have vaccinated a very large percentage of our population. We may not reach the exact goal of 70%, but a large percentage would be achieved. And that definitely will have an impact on how the third wave or the conclusion of this pandemic happens. If you have to draw examples from the previous pandemic, which happened 100 years back, there also there were 3 peaks. And the third peak was a little better than the second, because obviously a lot of people were had antibodies, and then that gradually sort of peters off just like a jungle fire. So we just pray and hope that we don't see a third wave, because it's not really necessary that the third wave will come. So there is a likelihood that the infection may just gradually become endemic and not remain as an epidemic as it is today. So we have to just hope for that, but that does not mean we should not prepare ourselves for any other flare up which may happen.
So the last question, which is come in different forms, is really around everybody is looking for information on health during the pandemic. And while a lot of information is right information, a significant part of the information which is misinformation or the wrong information, which can actually be harmful to people. What are some of the lessons out of this? What are some of the recommendations you have in the way information is managed around healthcare, particularly the ones that can really have an adverse impact on someone's well-being and safety? And any thoughts, any reflections on that, Dr. Raghuvanshi?
Yeah, actually, this is a very, very complex topic. And to be honest, I think in today's age of, where all the information highways are open and they are open source, anybody can publish information, anybody can disseminate it. And it is something which is difficult, I think, for any government or a company to control. Of course, there are a lot of debates about this as to how the information should be, edited or looked at and or authenticated, etc. But I think that takes the debate on to the certain very fundamentals of human rights and privacy, etc. So because of that, I think it is very difficult for the government to put in any kind of control on how this information is generated and how it is disseminated. So I think the only way and suggestion I can give on this is that people have to learn to discern which information is credible and which is not. So here, the certain institutions which are well-established institutions, I think they have to take a responsibility to disseminate enough authentic information in these forums on the social media and other forms of communication. Unless that happens, then it will remain like that. See, it is like this. In the universe, there are, like, hundreds of say organisms, and if you have 80 organisms which are healthy, then only 20 are unhealthy. Whereas if you have 80 organisms unhealthy and the healthy ones are only 20, then the whole system becomes unhealthy. So if more and more authentic information is produced by credible institutions and disseminated, then automatically people will also say that, okay, this is information from Mayo Clinic versus this is an information from some some hospital in some unknown place. So that is where I think the responsibility of the larger and the more credible healthcare providers and doctors is there. And I think artificially controlling it in any way would be extremely difficult. It will be a logistic nightmare and it will be legally not possible to do. So I think some responsibility lies with the companies which disseminate such information as well. But I don't think I'm an expert on those issues, and I won't comment because this is a pretty political issue these days as well.
Sure. No, I think Dr. Raghuvanshi, thank you so much. I think many of the points what you have mentioned today have far-reaching implications, and we certainly will, from a NatHealth platform perspective, we will take your suggestions, very seriously. We look forward to working very closely with you. You are an integral part of NatHealth. I thank you for taking the time. You've really gone into depth into some of the most pressing questions. This particular interaction will be transcribed, and those of you who'd like to look at the blog version of it, you will be able to do so on the NatHealth social media handles, the NatHealth websites. This entire video will be also put up verbatim shortly there. You can also go and look at all our past eminent speakers who have spoken in the blog posts as a part of this series. We have another interaction that will be coming up the day after tomorrow. That is Thursday, and this would be at 5:05 p.m. with Mr. Himanshu Baid from Polymedicure Limited. We thank you, Dr. Raghuvanshi, again, and we look forward to continuing this discussion and interacting with all of you. And wish you all a pleasant evening and a wonderful week ahead. Thank you so much, Dr. Raghuvanshi.
Thank you.